So we did our project for the Becoming an Expert, and we have it ready to go, and we are going to share it really quickly. So let me see here. It is not on the right slide. Let me make sure we have it ready. Okay. So let me share my screen with everyone, being Haya and Dr. Pershi. Okay, so we did our Becoming an Expert project on the proper diagnosis of language disorders through testing. And it is me, Selma Tahat, along with my friend here, Haya.
Hi, Anopal.
Yeah.
Sorry.
Some people like to introduce themselves, some people don't. Okay.
It's okay.
We interchanged our information that we use between Dr. Pershi's work through her PowerPoints and other resources. So we will describe what's from Dr. Pershi and what is articles that we use as sources as well throughout the presentation.
So diagnosis are labels or descriptors for symptoms of a patient. It is when the client is said to meet a certain criteria of being in a group or not in a group. This is just a definition. Next slide. So counseling and diagnostic interview for an SLP. So on the left-hand side, I have written the counseling, important information. So counseling is the assistance or guidance in resolving a personal, social, or psychological problem and difficulties, especially by a professional. So as professionals, as SLPs, we have to gain the clients and the family members of the clients, their trust. We have to do this by being able to relate to them, talking to them, and helping them individually. So as SLPs, we welcome them by engaging them and listening to them, and we create like a safe place for them through honesty and genuine communication. And the parents are looking to us as SLPs for guidance and direction of where their child should be and how to know what's right of the diagnostic that they need to be in. So as professionals, we diagnose human beings, and we don't not just their ears or their mouths. So we need to help them in any form that they have. Like if they're depressed, if they're not depressed, if they're sad, or like they don't understand why their child has to have speech therapy, it's our job to help them understand in the best way possible why they're going through speech. So we first have to diagnose the child by doing an interview. So this is the interview is the first opportunity that an SLP has to meet with the parents and the client. The SLP needs to show that they are knowledgeable, professional, compassionate, understand, they have self-confidence, they listen and are trustworthy from the beginning in order to gain that client and the client's family's respect, and so that they know that we're here to help them and we're not against them. From the first impression, the SLP has to make sure they're showing all the characteristics that I just listed. So it's an long-lasting impression. So the whole focus during the interview is the client, his or her problem, and his or her needs. The goal is to uncover important information to help us diagnose the client. To properly engage the client and their family, an SLP has to refer to only to a prepared list of interview questions and refrain from writing notes during the interview process. By doing this, an SLP will have to ask for permission to record the session or the interview. So that way the SLP won't be having to take notes during the interview, and that way they can focus on the client and his or her family. So with not writing in front of the parents or the client, they will be more comfortable instead of like feeling nervous or anything while the speech pathologist is writing notes. So there's a couple of different ways that SLP can make sure that the interview process runs smoothly. They have to reflect and clarify what the client says. And they have to make sure to check in with the client and summarize the questions that are being asked. The SLP should ask powerful questions that are open-ended and thought-provoking questions, not questions that are yes or no or closed-ended questions. After the client or the clinician finishes with the interview and they reread and they finally come up with another meeting to meet with the client, the post-evaluation is basically having to flow talk, highlight positive and strengths of the child. They have to clarify the role as an SLP. They have to enlist the family in the diagnosis. They have to have written recommendations and have to be able to answer questions for the parents if they have any questions. So how does an SLP reach the diagnosis after having the interview? The SLP does this by three main ideas or concepts, which are the behavior, history, and clinical presentation. So the behavior is where the interactions happen, where you see the real life, the play of the child. The clinician can do this also by observing, by language sampling, and testing. So standardized tests to see how the behavior of the child has been impacted. Also the history, the past and the present. So looking at everything from the beginning till that day by using charts, reports, and interviews. So if there's any other diagnosis that the child has, any other interventions, other faculty that are involved, the SLP has to look at all that information to be able to reach a final diagnosis. The clinical presentation, which is the degree to which the individual meets the prototype of the diagnosis. So we determine as an SLP what we determine as an SLP. So we look at the similarities and differences of the prototype, the strengths, the weaknesses are also involved in this category, the successes and challenges, the preferences and dislikes of the client, what supports and challenges they have. So all the described events, circumstances, and characteristics that the client is going through help an SLP reach the diagnosis. So the next thing I want to talk about is the diagnostic process. So these are 4 questions that will help us find out if there's a problem and what we have to do to help them. So the first question is what could cause a problem? So this is where the case history is, the risk factors, family history, all that can help us with finding what could cause the problem. The second question would be, what are the child's deficits? So the deficits are associated with the primary diagnosis, if there's a secondary diagnosis, deficits that are happening during language sampling, language testing, deficits that the SLP observed during play, self-monitoring, the fine and gross motor, all those deficits that are reported by the caregivers will help us answer what are the deficits of the child. The third question that we're looking at to help us would be, what are the child's abilities? So these are the abilities that the SLP has documented through language sampling and language testing. The ones that we've observed during child's play and what the family informs us of what the child's ability is. Then the last question would be, what are the correct recommendations? So how this is basically informing us how to enhance abilities, how to improve the deficits, how language growth is through the forms of development. Any referrals that we receive will help us lead to to find out if there is a problem and what to do. The next thing I want to talk about is diagnostic report writing. So this is a document in our profession that has to be written to be in files for the client, that we have done a diagnostic interview and we have reached to a specific diagnose for the child or for the client. So the role is to provide and support for students and student clinicians in the area, and to provide a resource for instructors and supervisors who teach the clinical report writing skills. So this is, so why is this report writing efficient? Because it provides an analysis of information obtained through the client and the family interview, assessment, and the client's interventions. It provides recommendations to what to do in therapy. The clinical reports are a means of written communication between the clinician, other professionals, and outside faculty. It also is important because it reflects the professionalism of the SLP and the faculty where the documents have been originated. So these diagnostic report writings will help inform of what's going on with the child.
Thank you so much, Haya. So Haya did a good job leading me into my topic. So Haya started off with the professionalism that we deal with as clinicians with our clients. So how we're going to be building that relationship with the client in order to figure out what their diagnosis is, the rhetorical questions that we're going to be asking ourselves as a clinician, and then finally how we do the proper report writing in our diagnostics. So now I'm going to be talking about the actual assessments that we use in diagnosing our patients. So when we talk about the etiological approach, so what is its relation to assessment? So when looking at the etiological approach, we are looking at our clients or our patient's skills in motor, sensory, and cognitive function. So we want to look at each of these aspects individually as well as cohesively. So do they have the motor skills? Do they have the sensory skills? And do they have the cognitive skills? Yes. How do they flow together? That's something else. So we want to look at these aspects individually as well as together. We are also going to be looking at if they have any damage to their central nervous system or any severe emotional dysfunction when put into social situations. And this will help us determine the type of either impairment or disorder. So each of these things coincide with each other. If they have a central nervous system issue, that could be related to their motor function. If they have severe emotional dysfunction, that could be related to their cognitive function. So these two aspects in relation to assessment kind of melt together because they each are related to one another. So why is this specific approach necessary but not efficient? So this approach is not efficient enough because we still have to use the descriptive developmental approach, which I'm going to talk about in the next slide. And that's our more preferred approach. It's the one that's going to be better for diagnosis because we have to use that approach along with it in order to describe the actual nature of the impairment and how the impairment has affected the child's language directly. So the ideological approach, yes, we have it, but we have to have it along with the descriptive developmental approach in order to properly diagnose our clients or our patients. So, going into the descriptive developmental approach. So, the purpose of the descriptive developmental approach is to diagnose children with issues in areas of linguistics related to phonology, morphology, and syntax. Also, areas of difficulty related to semantic development include understanding vocabulary and using those vocabulary, the meanings of those vocabulary to describe ideas. That's an important aspect to have. And lastly, the descriptive developmental approach dissects difficulties in language related to social adjustments and use of language in various settings. So yes, you have the language, but are you able to use the language in various social situations? Social settings are a big part of our language, right? It's a part of speech because you might be able to talk, you know, in your comfort, but then when you're put in other social settings, you know, we want to be able to see what the child can do in those different environments. So components of language disorder where you may need to use the descriptive language approach that we have here, or if the child does not know how to use their components of language altogether. So this doesn't mean that they don't have the different components of language, which are use, form, and content, but they might not be able to use them cohesively. Again, it's all about cohesiveness like we talked about previously. You may have this, you may have motor, you may have a little bit of motor, a little bit of sensory, but are you able to use it together? And especially when you're talking about the aspect of language, that's very important. You know, you might have form and use, but you don't have content. That's a big chunk of language that you're missing. That's kind of gonna set you back a little bit and cause diagnosis for a possible impairment or disorder. So we want to make sure that they have them all cohesively. And as a reminder that the purpose of this approach is to provide the explanation for the nature of the language impairment. So kind of the background of the nature impairment, what's going on, why do they have this impairment or disorder? And that you cannot diagnose without this approach. So like I said, this approach is kind of the most important, the one that we want to make sure we understand very well, because we can't have the ideological approach on its own. So there's a few terminology. I'm gonna move you over here. Okay, so there's a few definitions that we should kind of have in our bank that we want to have registered in our minds kind of always when we're working with these clients and when we're talking about testing. So first we have static assessment. This is a one-time only test to see how the child is performing. And we want to pay close attention to procedure using proper measure when we're talking about static assessment. Next, we're talking about task analysis. And as a speech language pathologist, we have to break down larger tasks into smaller ones so that they are easier for our children with language impairments or disorders to tackle. So this is a given. You know, it's hard for kids to kind of have this big, huge assignment kind of plopped in front of them. We have to break things down in bits and pieces, and I feel like that's in everything we do as a speech pathologist. You know, it goes from sentences to words, to word parts, to sounds, little by little, everything we have to break down in chunks because it's overwhelming. It's a lot for these kids. Then we have zone of proximal development, which is the amount of social interaction or stimulation the child needs. what the child can or can't do on their own. So we talk about this all the time in our in our clinical that we're doing right now. How many cues do they need? How many prompts do they need in order to output what I need from them? And that's what we need to know in our testing, because we need to know how much the child does and doesn't know on their own in order to be able to place them in the proper intervention. Next, we have functional outcome. So what the child will be able to do in their real speech life. That's the whole purpose of why they're with us. That's the whole purpose of why we're testing them, so we can get them in the right place so that eventually they don't need that extra help, as we call it, anymore. So while we test for language, we want to make sure the child is able to communicate in everyday interactions with others. So it's speech, it's language, it's real life situations, how they're going to be out on their own. One day they're going to, they want to make friends, they want to get a job, their kids grow so fast. So lastly, we have testing effects, which is the aftermath of being tested. So this can be positive or negative. Standardized testing can be very overwhelming for children, and it can kind of have this negative effect on them where they, look at it in a bad light, and it might affect their scoring. And then some people who do well on standardized tests, obviously they're going to have a positive look. They might like taking standardized tests because they know they usually get higher scores. So there's all kinds of effects when it comes to testing. It doesn't let me use the arrow. Okay. Why? Hold on 1 second.
All right, so these are some more vocabulary words that go with the diagnosis, interview, and testing that we've been talking about. So open-ended questions are questions that cannot be answered with a simple yes or no. So there's two types of open-ended questions, which are the divergent questions and the convergent questions. So the divergent questions are questions using expressive vocabulary. These often require students to analyze, and they have to think more before they answer the question. And then the convergent questions are more one correct answer. So they don't have to overthink it. This is the right answer, and there's nothing else other than that. Then we have test bias that differentiates test validity and the test scores for groups. Then focal disorders, which is one system that is affected, and diffusion disorders that are all the systems are affected.
Okay. So another thing that we use in terms of testing is checklists. So checklists are similar to standardized tests in that they compare the child to typically developing children by comparing the child being tested to a number of children that had data, collected on them. So we're going to pair this one child, and we're going to see if they fit the norms or a typical child their age based on data we collected from a sample of a group of children similar in their developing age who develop normally or typically. We're going to see how they fit within the range, within the spectrum. And checklists are a form of descriptive testing and a hierarchy that believes that early behaviors in children develop as later behaviors will develop when the child grows and learns. So it's just saying naturally in the hierarchy of development, you start off simply with your simple skills and behaviors, and as you get older, naturally you have other behaviors that come along. And checklists are also a practical tool because they are easy for parents to understand what the child is being assessed on. You can give the parent kind of, like, we live in Ohio, there's Ohio guidelines as to where a child should be depending on their age and grade level. So they have those listings that you're able to show to the parent, this is what the state says, where the needs we, need to be at, what we need to meet, the expectations. So that's something that's easy for the parent to understand. They can, they have a physical list literally, but then they can kind of mentally keep track of how their child's doing based on how they pay attention in the way they talk, the way they interact. And then they're a nice tool for us as speech pathologists, because we can literally have a checklist in our sessions of what we're looking for out of the child based on, what testing says they should have, and we can check off in our assessment what we're looking for as we go through a session or as we go through an actual test, what check marks they need to be meeting in that test. Oh my goodness. Okay.
All right, so test validity is the property of the test scores and is a singular concept. It measures how well a test score assists the contract it claims to test, which is the most important, and it reveals measures of a test effectiveness. So if this test is good and if it's there's good results from it, that's test validity. There's several different types of validity tests, such as the face validity, content validity, content validity. So with a test score cannot be valid without being reliable. That's all I got.
So, like Haya said, a test cannot be valid without being reliable. So, these are the aspects of reliability that I have here for you. So the textbook validity and reliability go hand in hand, as Haya was saying. So the textbook definition of reliability is the likelihood that upon the same procedure of administration of a test, you would yield the same or similar results over and over again. So I follow the procedure that I have in this test again and again, a 10th time, 1, 2, 3, 10 times, I'm gonna yield or produce the same or almost the same score every time. And excuse me, in order to establish this sense of reliability in your testing, you must have multiple versions of your same test. So you have multiple versions of the test and you still yield the same score. You're able to split your scores and compare their similarity and still have similarity within splitting the scores. And you're also able to test again later and still yield similar results. Again, all three of these aspects together prove that your test is reliable. You're making sure that your test is reliable. And statistics can determine if two sets of results give a similar score, because when you average two sets of scores, if both scores are similar and you average them, you're gonna have an overall average that's similar as well. So that's how you know that you are also producing a reliable test.
Okay, so this next slide is about the article that we chose as one of our sources using test scores. So the article was called "Limitations of Age Quantitative Scores in Reporting the Results of Norm Referenced Tests." So this study investigated scores for 19-year-old participants and examined the relationship between the participants' standard scores and their AE scores. So the scores on their test determined whether a client is performing within the average range or whether a delay or impairment is present. So one of the common types of score available for reporting the performance on a standardized test is age equivalent, which is AE scores. AE scores represent the mean or the median score for normative samples for a particular age group. So AE scores are used for SLPs to explain the scores, to explain the standardized scores to parents. So the test scores that children take on standardized tests, the AE scores help the SLP explain them to the parents. So norm referenced standardized tests are mostly used by SLPs. But the AE scores have limitations, and those limitations are that the AE doesn't take in consideration the range of the normal performance for individuals whose scores fall within the average range. The scores promote typological thinking, and they lack of information that is provided to a test taker performance on a given test. The limitations of AE scores are also that the method in which these scores are delivered. Another problem that these AE scores have is that it relates to children who receive extremely high or low scores. So a child could receive a very high score or a very low score, and it doesn't average in the range of the typical age. Another problem that causes limitations for the AE scores are that the scores falsely imply that the abilities increase at a constant rate from year to year. And those limitations of the AE scores don't add up with the results that the students take. So throughout the study, the method and the procedures of the study are that there are about 50 individuals who participated in the study, all from the age of 19 to 19 and 11 months. 32% of them are males, 68% female, 98% of them were college students, 34% were freshmen, 64% were sophomores. All the students that took the standardized tests were all fluent in English. So they had each child, take the test, just one test, one standardized test to see as the results. So the results of the study revealed that, as expected, the standardized scores were normally distributed. The AE scores were unevenly distributed, making the interpretation problematic because of the limitations that I described before. But this article I thought was good because this information can be used to assist SLPs with evidence-based practice when reporting performances on standardized tests.
So I read the other article that we chose for our sources for our project. So mine was about early vocabulary testing in our Unit 1. And mine was the title was A Psychometric Analysis of Childhood Vocabulary Tests. So I focused a lot on the different aspects of standardized vocabulary testing that they talk about. And then in the article, they described their own research that they did on an example of creating a standardized vocabulary test where they yielded a reliable and valid test and test scores. But I wanted to talk about the different aspects of the creating a vocabulary test and just the different vocabulary that they used, terminology, because I don't want to get us confused there, the terminology that they used about vocabulary testing. So when we're talking about this type of vocabulary testing, we're not talking about vocab tests that, the teachers give based on, a book that they read in class. We're talking about standardized tests. So we have high stakes standardized tests. So this is where results in these tests are used to diagnose a child or determine their placement in school. So this type of testing can also be used to decide the type of treatment for your child. So this is kind of where we're looking at, what more the diagnosis side of the child, but we're not actually diagnosing them. We're just figuring out, again, going back to kind of the spectrum that they fit on, where they belong, how well they're doing compared to the norm or the typical, and if they need any type of intervention possibly. Then when we talk about low stakes, this is just what we use in terms of standardized testing for screening or collecting data for different environments that are under review. So this is kind of used to, as the data that we use to compare a child to a number of children, like how I mentioned earlier. So it's not really, you're talking about one child, but you're reviewing kind of the general environment than you are about placement. So low stakes is more about the environment, high stakes is more about the placement and treatment. So we have 3 different aspects of creating a proper standardized vocabulary test. So it's kind of a little sandwich here where you have the standardized test sample, reliability, and validity. Again, we kind of mentioned all of these things previously using what we've learned in class and with Dr. Pershey, and this article does a great job of putting all that together. So what does your standardized sample consist of, or what is a standardized sample? So one characteristics of a good sample is that you need to have, a large sample. We're not talking 10, 15, we're talking 100. We want a large sample in order to get the best results for our research, and the sample must also be able to fit the population that the test is for. So, if it's about children, the sample should consist of children, not adults. You're not going to compare, the vocabulary of 5-year-olds to the vocabulary of 30-year-olds. Obviously, you want to make sure your sample is consisting of the correct population, so age. Also, it's fair to have various cultures, races in your sample because, kids go to school among all different backgrounds, with people from all different backgrounds, different types of environment, economics, things like that. Those affect, the results you're going to yield as well. And then in the article, they also talked about the debate on whether or not children who have language impairments or various language abilities should be incorporated in the study, or in a sample that you'll be using for your research. In my personal opinion, I do think they should. I know some say it will skew the results, but I would have to disagree because oftentimes all kinds of kids have impairments or disorders going on, and I feel like it'll create a more diverse sample when you have a little bit of that in your sample. Not saying that every kid in the population, or sample of the population should have an impairment or disorder, but I think it's okay because that is typical, that is what we see often. So it wouldn't hurt to have a few scattered in the sample that do have that. I don't think it would skew it. That's just my personal professional opinion as a learning speech language pathologist. I don't know if that would change in the long run, but that's what I think right now. And the sample must also come from recent studies. So the sample you use, the studies you take on them, it has to be recent. Like things like IQ, for instance. Like we don't really use the idea of IQ. They talked about that in the article. So you don't want to use a sample that, said, oh, children with this IQ were used only in the sample. Now we know that IQ doesn't really have the same hold, the same meaning as different types of testing that we use now. Then again, we're talking about reliability, as we mentioned earlier. So in this article, it described reliability a little bit more in depth for us. So we have the general definition of reliability, which is consistency in your testing, which we mentioned several times. So when you're talking about consistency with your examiners, that's when we use the term inter-rater reliability. So the examiners are using the same procedure over and over, the same type of administration over and over. That's what we call inter-rater reliability. I hope I'm pronouncing that correctly. Then we have where we are using consistent items within our testing. That is called internal reliability. So internal because these are the bits within our test. Those need to be consistent throughout. That's what we call internal reliability. And then lastly, having consistency over time, which we also mentioned previously. That's called test, retest reliability. So if I use this test a month ago, and if I use it now, between now and a month ago, I should be able to still yield a consistent result with the test from a month ago, or my results from now should be similar to the results from a month ago. And then the last part of our sandwich, I guess the second bun, I'm gonna say the first bun is the standardized sample, the meat is the reliability, and then the second bun is the validity. And that is that's when we ask ourselves, again, how well does this test measure what it claims to be measuring or testing? So is this test even pursuing the purpose that it's for? Is it giving us data on what we are trying to measure, what we're testing? So the way we know this is, are things correlating? We look at correlations or trends within our testing. We also compare the several correlations, and we see, if they have positive correlations, negative correlations, then that means we are yielding a valid test with valid results. Resources will be attached at the end, in our discussion board.
Yeah.
And we will have that ready to go. So we really appreciate you taking the time to hear our expertise on testing and diagnostics.
Thank you.